Now, right. Okay, welcome everybody to the England and Wales ITP Patient Support Group meeting for November, the last day of November 2022. The ITP clinical experts we have with us tonight are Professor Adrian Newland, who's one of our medical advisors and also Chair of Trustees of the Association. We also, it's my pleasure to introduce to you another one of our medical advisors, Dr. Will Lester. Will has helped us out at numerous ITP patient conferences pre-COVID over the years. In addition, we've got board members, Mr. Derek Elston and Mr. Anthony Hurd with us, and also senior, and she hates me when I say this, as senior patient advisor, Rhonda Anderson, here to actually input any advice and guidance as well. Again, just a second reminder, because I have forgotten once in the past that we are recording this. So has anyone got any questions that they would like to dive in with before we, to kick off? Anyone? Put your hand up if you have. Okay, no one first. So I've got one. And this is from Tina, and I know Tina's online somewhere because I saw her name come up. Yeah. What do you think is the best and safest treatment options for the patient when they don't respond to steroids? If these two things don't or can't go together, then which is the best and which is the safest, or is it totally down to the individual? The side effects of some of the medications are as frustrating as the condition of ITP itself. Also, is there any way that we might be able to, in the future, as a secondary question, to check our own platelet level, much like the diabetes do, or even when they check the glucose? So, Adrian, do you want to kick off with that one? Anything in a
Yes, I shall unmute. No, I don't want to be told to unmute twice today. Well, I mean, they're both interesting questions, and up to a point, there's an element of choice after steroids is as much down to the physician and discussion with the patient, and also it also depends on the patient's own condition, what some of their background problems are, and whether the treatment itself could make them worse. And one has to admit that all treatments have side effects. Not all the side effects affect every patient. And indeed, if you read the inserts in some of the boxes of tablets, you can become extremely alarmed because the companies now completely cover their back and will put down absolutely everything. I mean, for instance, if you look at the insert for azathioprine, you'll see it causes thrombocytopenia, and many patients have said that this causes thrombocytopenia, and that's what we're treating. And you have to explain that there's a different method of action, and the thrombocytopenia is for higher doses and for different conditions. But in general, most physicians will follow guidelines and will use treatments depending on what they are and what their experience is. Many people now, for second line, would often go on to the thrombopoietins if they have them available. In theory, they can be given second line, although they're not. I know that not all commissioners will pay for them as second line. They can sometimes. There is an element of postcode prescribing in the UK. Many of us used to use, or some still do, a course of rituximab before going on to something else, purely because it's 4 injections over 4 weeks, and if there's a response, it's often relatively prolonged and doesn't and gives a significant time off treatment. It's not a cure-all, but patients who respond well may have some periods of remission that don't require other treatments, and that of itself is value. I mean, there are obviously some issues about giving rituximab as well, and it's not quite as popular as it was, but still relatively widely used. So I would think that those two are the main options, and I'll ask Will in a minute to come on to that. The issue of checking platelets at home is a very interesting one, because there's been a lot of discussion and a lot of work for patients receiving chemotherapy about whether they can have a platelet count at home and send those results in, or their white count and hemoglobin as well, so that treatment can be prepared. It's not available at the moment, but I know that some of the diagnostic companies are looking at diagnostics that allow a finger prick sample with the diagnosis at home using a small little box that then will send the results to the hospital, who can then plan. So it means you don't have to go in and have a blood test and wait for the chemotherapy. But most places now, certainly if you're receiving chemotherapy, will get you up a day or two before to check the platelet count. That, of course, requires a trek. Some GPs will be extremely helpful and will pre-do a check as well, so you've got that available. And GPs are often closer, and it's more handy than going to a hospital to have it done. But it's still relatively unsatisfactory. But I would see in the foreseeable future, and by that I mean possibly the next 3, 4, 5 years, there will be an ability to actually do a platelet count. Of course, measuring things like blood sugars is much easier than measuring platelets, which are obviously elements in the blood that are more difficult in finger prick samples. But the technology is certainly being looked at.
Okay, Will, have you got anything to add?
Yeah, I mean, it really is a great question. I mean, we were just talking earlier about the decision support document that you did, and I think Adrian helped to write it. And that is very helpful when you're looking at anything beyond first-line therapies. And I think it's really, really important that we minimize side effects. And I think historically, a lot of us used mycophenolate, and we still do use it. But we know now from this trial called the FLIGHT study that was done in the UK that quite a few people do get side effects with mycophenolate. So we have to be a bit cautious about that. And during COVID, we were quite worried about giving people immune suppression. We were worried that if we suppress your immune system with ITP therapy, that the COVID infection may be worse. So we were given permission to use the TPO receptor agonists that Adrian mentioned. And you know, on the whole, it was pretty successful and pretty well tolerated. And I think the only barrier is this issue, as Adrian mentioned, about the licensing is for chronic ITP. So officially speaking, it's not supposed to be used for new ITP, but there is a bit of a postcode lottery in that. Certainly where I work, we don't have scrutiny. We are allowed to use it at our discretion. And yeah, I think until we do get the ability to have point of care platelet testing, I think the very least you should expect is that when you have your platelet count checked, that you should be allowed to be given that result immediately as soon as it's done. Historically, a clinician would get a result from you and then look at it and then maybe will or will not pass it on to you. But I think these days, your blood results should really be go to you immediately. And many hospitals will have a system where, I mean, at our hospital, it's called My Health, where you, as long as you're registered, then as soon as the result comes off the machine, it will ping to you. You can look it up yourself. And I think access to your own results is really important, even if it's not a point of care test. And I think that's an expectation. I think you should expect to be able to do that.
Yeah, I just coming back on that, I think that's a really important point. Certainly many areas in London and my area as well has something called patient preference. And again, that's an app that we have. And whenever a GP requests a test, or whether the hospital requests a test, whether you're an inpatient or an outpatient, that result is available for you as soon as it's reported. And I think that's been a real boon in being able to check. I think the other issue that we'll mention, which I think is also very important, I'll reiterate, is that we want to minimize side effects. And actually, a question to ask is, do you actually require treatment? You may respond to steroids and the count may fall, but if you're not having problems and the count isn't dropping to levels that we consider are likely to be compatible with bleeding or spontaneous bleeding, maybe you don't need treatment, and maybe you can just be followed and see what happens to the count. So that's a discussion to have, and I think that's an issue that the shared discussion document also highlights as well.
Okay, anyone got any questions? Put your hands up if you have. David, have you got a question? Just put your hand up. Yeah, you're on mute, sir.
I'm a very new patient, 5 weeks. I'm totally confused by all these names of treatments. I have read them all. I'm coming down off of a high dose of steroids at the moment. Has anybody suggested to the producers that they actually simplify these names of all the treatments? Because they are totally confusing, especially when you're talking about them and I haven't heard the names spoken about properly yet, apart from very briefly with a consultant.
Will, would you like to go first with that one?
Yeah, I mean, it's a good point. I mean, for any drug, there is an official name that we use as doctors, and then there's a trade name. And they try to make the trade names a little bit more pronounceable, but what we often end up doing is using acronyms to make it easy. So I mentioned this drug called mycophenolate, we'll call it MMF. And the drug rituximab, we might just call it Ritux. But there is unfortunately every aspect of life has its own special language, whether in computing or whatever you're doing. And in medicine, it's the same. There is a special language, which unfortunately, to some extent, there's no way around it. You have to learn it. And yeah, I agree. I think especially some of the very, very modern therapies, some of these complex antibody therapies, they are very difficult to pronounce the names. And, you know, some of us pronounce them differently from each other as well. And no one knows how to pronounce them properly. So it is an issue, I agree. But I don't think there's any easy way around it. I don't know what Adrian thinks.
I think that's absolutely right. It's we do in medicine. You're actually encouraged to use what they call the generic name, which is the name of the molecule itself. Now, for some of the ones we use, so something like the thrombopoietins, rimiplostin is Nplate, eltrombopag is Revolade. It's something different in other countries, but certainly many common medicines that have been around for a while, which are made by different companies, may have different trade names. So you can have the same drug that comes in different names. I mean, I take antihypertensive therapy, and I'm very much dependent on what my chemist gives me. And you know, for this 2 months, I'll get the same drug with one name, and when I go and renew the prescription, they'll give me something from a different manufacturer. And that can be very confusing. It's okay for me because I understand these things, but if you're a patient, you do worry, and you worry that, well, if it's a different manufacturer, is it actually the same thing? It doesn't have the same impact. But Will's right. It's just one of these convoluted things in medicine that unfortunately you get used to as you become what we call the experienced patient.
Thank you.
Thank you, David.
David,
Right.
what I certainly can sympathise, David. I have been living with ITP for 16 years now, and certainly, like you, when I was first diagnosed, it sent my mind into a spin. I have to say, trying to come to terms with all the various terms and drugs and treatments. But I mean, the thing after all this time, I've kind of got in my mind fixed now is that essentially there are two types of treatment. One group of drugs designed to suppress your immune system, the other to stimulate your system to produce more platelets. So what you're going through now is the prednisolone steroid phase, which is the first treatment that we probably all have become familiar with over the years. In that group of drugs, other than prednisolone, there is azathioprine, which I have tried, mycophenolate mofetil, which I am still on and is working very well for me, rituximab, which I've had twice. So those are examples of immune suppressing drugs. So that's suppressing your immune system. And as was alluded to just now, you may often be pushed across to the other group of drugs, which are the eltrombopags that were mentioned, etc., to stimulate your system to produce more platelets. All of this is detailed very well on the ITP Support Association website under the heading of treatments. So bear in mind that there are just basically, you can group them into 2 separate groups, and if you keep that in your mind, then I think that helps to simplify it. But what I'm sure others will probably cross with other people on the discussion tonight, that things have moved on dramatically in the recent times with the treatment options available. I mean, in the 16 years that I've been living with the illness, you know, we've got lots more treatment options now, and treatment options that are specifically designed for the treatment of ITP. So bear in mind that a lot of the immune suppressing drugs were not designed for ITP patients or to treat ITP. They were designed for other things, but we've just adopted them in the treatment of ITP over the years because they've seemed to have some means of working. They have worked for lots of people, but I'm sure as we go through the evening, there'll be other people that will give you their views too. So
there will. There's several people with their hand up. Bonnie, before I go to you, Rhonda, is your question about the naming convention for the drugs?
No, I was just going to say, you know, as a patient supporter, that it's really important that people do ask their clinicians to explain things, ask them to write names down, and also don't be frightened to challenge them as well, because they might say, well, we think you should have this treatment. And you might say, well, actually, I haven't got too many symptoms, so really, do I need any treatment? So, you know, these are the sort of issues that you need to come to terms with, come to grips with. And Anthony has made a very good point to look at the ITP website, perhaps print off the list of drugs, you know, stick it on the fridge or something. Have a look at it now and then so that you become a bit familiar with it. And so if your doctor then says, well, I think this would be a good idea, you know, this isn't the first time you've heard of it and you know something about it, so that you can ask those questions that are relevant to you and your lifestyle. And I think this is how we had the, you know, decision-making tool, which was really helpful, where patients are, you know, partners in their own care. And I think that's really important. And our advisors are absolutely wonderful at that. Not all doctors are. So it's a good idea to be ready to ask. It is confusing. It is sometimes very upsetting to have a diagnosis of something like this that you've never heard of. But, you know, if you go along with it and work it through, I wish you well, and I hope that helps.
Thank you, Rhonda. Bonnie, you got your hand up?
Yeah, it was just a question, actually. I've had ITP for 6 years. I've been through the kind of usual journey of different medications, and I've actually returned to Eltrombopag, having done a few other things and lost responsiveness. Just wanted to talk about hemoglobin. Mine's creeping up to sort of like 160. And I just wanted to know whether that is a side effect of something like Eltrombopag at 75 milligrams, or could it be something about having an iron infusion 3 or 4 months ago, or is it something completely different? And I just wondered if there's any kind of relationship between those things.
Right, Adrian?
I'll start chatting about that. I mean, it's Eltrombopag can actually hit the stem cell in the bone marrow, and in patients with what we call aplastic anemia, where all the elements of the bone marrow are depressed, at higher doses it can actually, in quite a proportion, push the hemoglobin up, the white count up, and the platelets up. But the doses that we normally use for that are about 150. I'm not aware that at the lower doses that it has any impact on hemoglobin at all. It's quite possible. I mean, for 16 or 160 in the new terminology, for a woman is sort of upper level of normal. But if you had an iron infusion and you're iron deficient, it's quite possible that you're producing more hemoglobin. I think the important thing is just actually for that to be monitored and keep an eye on it. There are some very rare conditions where the bone marrow produces too many red cells. It often produces too many white cells and platelets as well, but that's unusual, and at 16 it's not something that we would necessarily consider, but it is something just to keep an eye on when you're having when you have your blood test done. But I suspect it's more related to the iron infusion, and certainly isn't at that level, isn't a risk to you.
It's really interesting you say about making platelets go higher and potentially your hemoglobin, because I recently have had this really weird spike of a good platelet count. I'm always about 40, and in the last sort of 3 months, which has tied in with my hemoglobin being a bit more raised and an iron infusion, which I think also makes my platelets go up bizarrely. I'm like at 100, 109, and I haven't been like that for 6 years. So it feels like everything has just suddenly kind of taken off a little bit.
Yes. I mean, certainly it depends why you're iron deficient, and sometimes when patients bleed a little bit, the bleeding can cause the patient platelets to be used up, and they may fall a little bit anyway. If you've had an underlying infection or another problem, that can sometimes stimulate the bone marrow and the platelets to go up temporarily as well. So there's quite a complicated interaction between all these things.
Because what is hemocrit? Because my hemocrit is also slightly higher than it usually is as well.
The hemocrit is an estimation of how much hemoglobin you've got. It's
right. Okay. Same sort of thing.
Yes. To put it crudely, it's the percentage of your blood that's made up of red cells.
Okay.
It's normally around 50%, and the hematocrit goes up a bit when your red cells go up,
right.
and it falls when you become anemic. So it's just a measure of, and it's another crude measure of what your hemoglobin's doing.
And if your hemoglobin is higher, do you get any side effects with that, like headaches or fatigue, or is there anything with that, or not really at 160?
Not at those sort of levels.
Perfect.
No, you wouldn't have a problem.
Really helpful. Thank you so much.
Thank you, Bonnie. Derek, you got your hand up?
Yes, just a very simple question directed at Will and Adrian. Would you treat ITP patients differently if they don't bleed, or if they do bleed? Maybe I should qualify that and say for 10 years I lived on a count of 10 with no medication, quite happily. So I don't know, Adrian.
Do you want to comment on that, Will?
Yeah, I mean, basically, the symptoms are the key thing, not the number. And we often look at these numbers. We go 10 or 12, and we obsess about these numbers. But if you look down the microscope at a person's blood film and you look at the platelets, and if you see great big juicy platelets, often they're really effective platelets. Numerically they are probably being undercounted by the automated machines. And so the number isn't everything. The symptoms are everything. And no treatment is often the best treatment, because you get no side effects, no complications. And so absolutely, I don't personally use a particular cutoff for treatment. I would use symptoms for treatment. And bear in mind that, say, that automated number that gets generated may be an underestimate of your true platelet mass, we call it, which is the amount of platelets that are available to stop you bleeding.
Yes, I mean, there was a study some while back that measured platelets by these machines that we all measure platelets by, and then doing a much more precise count, which takes a much longer and is more complicated, using something called a flow cytometer. And in a significant portion of patients, these multiple analyzers always slightly undermeasured the platelet count, because the bigger platelets, when they go through these machines, were being classed as red cells, and so weren't being counted. So I think as clinicians, as hematologists, for a long time, we've actually said, don't obsess about the count. Your count can fluctuate. The count fluctuates in everybody. It gets a bit more alarming if you're running a count of 20 and it drops by 5 or goes up by 5. For someone like me, whose platelet count is hopefully normal, mine will fluctuate during the day. If you went and ran up and down stairs and then took a platelet count, it would have gone up, because your bone marrow pushes more out. But as Will said, it's what the platelets are doing that counts. So if you've got a count that's supposedly 10, but you're not bleeding, those platelets are working. And unless you're a midfield enforcer for a football team, to use a popular analogy with the World Cup going on, it doesn't matter. If you're just doing everyday things, you can run a platelet count of 10 or 15 or 20 because you're not at risk. And so the important point is how you are and what your problems are. And if there are no problems, then if there are no potential risks within your lifestyle, then you can leave things.
Great answer. Right, Nigel Oakland, you've got your hand up, sir.
Hi, yeah. My question is slightly different. It's fatigue. I've had ITP for about 16 months now, and after my diagnosis, I literally slept for 18 hours a day for 3 months, and I still can't sort of get over the fatigue, both mental and physical. I started out, like most people, on steroids that didn't work for me. Eltromapag did slowly increase my platelet count, and then went on to robiplostim, which has actually got me into a good, safe level now. But whatever platelet count I have, it doesn't seem to affect my ability to improve my fatigue or fitness or mental agility. And I also feel the cold like crazy now.
Right, who wants to answer that? I see Anthony putting his finger up there.
Yeah,
Will, would you like to answer that
certainly
one?
all things that I recognise in my experience. So, but again, I'll let other people come in and answer it. But there is another very good video available on our YouTube channel if people want to watch it about ITP and fatigue. It explains why we get fatigued. It also explains some of the things we can do to try and combat those signs of fatigue. So again, a plug really for the YouTube channel. It's got a superb video on there about ITP and fatigue. So if you look it up, please, you'll get a lot from it, I can assure you.
I've watched it.
Have you?
Yeah, it doesn't seem to help. I'm
it's
also diabetic as well.
all right.
When I was diagnosed with diabetes, I managed to change my lifestyle and sort of master the disease. So it's in remission. But everything I try with ITP doesn't have an effect where without sounding a goody-goody, I follow the rules as much as possible.
I know that a lot of the treatments don't help either, do they? I mean, prednisolone and mycophenolate keeps you up at night. Both of those have made sure that I don't sleep that well. But again, you have to adjust things around that. So I sympathise, having a lot of the same issues. But obviously, let's see what other people throw into the equation. I'll see what
Will, from a clinical perspective, you got to.
Yeah, I mean, you may have heard about this IWISH study, which looks at the symptoms that people with ITP were getting acutely and at long term. And unfortunately, fatigue and lethargy is really an absolute primary key symptom. And I still don't think we fully understand the mechanism, because some people are lucky, and if you improve their platelet count with, say, romiplostim N-plate or another drug, the fatigue improves, but not necessarily always. And I there are theories, but I don't think we fully understand it. I don't know if Adrian's got any lead theories at the moment, but it is a genuine issue which I think we still haven't cracked.
Can I just interrupt there? That my doctor did recommend that I recommend me to a fatigue clinic, and I got declined on that because my fatigue wasn't ME or chronic fatigue syndrome. So wrong type of fatigue. It just makes you wonder where you've got to go to get advice and help.
I'm not sure anyone knows what the wrong type of fatigue is. I mean, there's some very interesting theories about why people with ITP do get fatigued. And there are multiple reasons, some of them related to the ITP itself. And it's quite clear that some patients can come and see you and say, I think my platelet count must have fallen because I've suddenly felt really knackered over the last few weeks, and indeed it has. And quite often when the platelet count goes up, the fatigue goes. But in a third, there's still some background fatigue, some related to the drugs, but some may be related to the disease itself or some other background condition. But there is no straightforward treatment for fatigue. There's nothing you can give you that will perk you up, which is, although there's work going on. And I mean, the point that Anthony made about the video, it's Cindy Newland, who's one of our US advisors, who gave a talk at last year's convention, and as he said, that's still available on the YouTube site, and there's a very good talk about it, but it isn't the sort of talk that says this is what causes it, this is what we do, and this is what's going to happen. It's very much potluck as to whether you're one of the lucky persons, the count goes up and your fatigue clears. There's still going to be an element of people who get quite fatigued, who remain fatigued. Not as many as used to be when we first started looking at this about 10 years ago, when in fact it was the ITP Association did a questionnaire looking at fatigue and found that a third of patients with ITP were profoundly fatigued, and a good third were equally quite moderately fatigued as well. So over half of patients with ITP had some element of fatigue that impacted on their quality of life. And that actually got us very interested in looking at this. And the Americans did something similar that looked at it. And as Will said, the IWISH study, which is an international study, is looking very similarly at it. But there are no specific treatments, I'm afraid. All we can do is try and treat the disease. But sort of issues, it's disappointing that you weren't allowed to go to the fatigue clinic, because I think the general understanding of fatigue, whether it's related to MS or diabetes or other conditions, is equally applicable to ITP, and some discussions about changes of lifestyle may be quite helpful from someone who understands that.
I do feel I've changed my lifestyle, I say without sounding a goody-goody, to be doing pretty much all the right things. Exercise, don't smoke, hardly drink, cook from scratch, use natural ingredients wherever possible. I've bought myself an exercise bike. I go for country walks. It's having some guidance to actually find something that's going to improve it.
I mean, all I can say is you're doing the right sort of things that any general physician would recommend, and I can only congratulate you on what you're trying to do. It's quite possible that if your platelet count is up but isn't normal, that you've still got quite an active bone marrow. And we know that some of the chemicals that are produced in the bone marrow by platelets turning over and being produced are associated with fatigue. So it's the fact that your platelet count may be higher normal doesn't mean you've still not got the ITP process going on in the background, and that of itself is associated with fatigue.
Okay, thanks very much, Nigel. We've got loads of people with a hand up. Sue Wheel, you're muted, Sue. That's it. Go ahead.
Yeah, my question really was on side effects. I've been on romiplostin now for about 18 months and had various rashes that have got worse and worse. My GP thought was lupus, now thinks it's lichen planus. And just wondered if other people have had those sort of problems with romiplostin. I'm waiting for a biopsy to confirm exactly what it is.
Okay. One of the clinicians, you want any? Is this a regular occurrence, a side effect with Romi?
I mean, it isn't a regular side effect with Romi, to be honest. I mean, in theory, it is possible. In theory. But it's not a common side effect. I think it really is important in your case, and that's what you're doing, is to look for potentially other causes.
Right, yeah, it was triggered virtually about a week or two after my first romiplostin.
Yeah, I wouldn't say definitely not, but it's not a common side effect. But often, sometimes when you're faced with an unusual side effect, and we see these with any drug that we use, sometimes the only way to really be sure at the end of the day is to change it to something else. And if it goes away, then yep, it is that drug. And if it doesn't, then no. And sometimes we do that. Sometimes we have to experiment and say, look, it may or may not be the drug. Do you want to try something else instead? I mean, you'd be reluctant to do that if you're responding really well to a treatment. It would be a shame to stop it, but yeah, there are other options, and I don't know if people are aware of this, but there is a new, so romiplostim and eltrombopag, we mentioned both of them. There is another TPO, we call them the TPO-RAs. It's a drug that stimulates the platelet-making cells in the bone marrow, the megakaryocytes, to make platelets. There's another one called avatrombopag, which can be taken with food. If you're on an eltrombopag, you might like the idea of that. And that, we think NICE are going to approve it on the 15th of December. So there may be a third option of that class of drug.
Yeah. We've been told with avatrombopag it has been approved. The press release went out a couple of weeks ago, and it will be available for pharmacies from the 15th of.
Yeah, so I think it's a formality. We expect it to be a formality, don't we? It's a draft approval.
Yeah.
They put their final appraisal document out saying they were approving it, and that'll just be rubber stamped, hopefully, in 2 or 3 weeks' time. It's unlikely that anyone would challenge it at this stage. I mean, the other point to make is that ITP is sometimes secondary to other conditions that aren't always apparent when patients present. I mean, a third of patients with ITP, when we do their initial assessment, will have antibodies in their blood that are seen in patients with lupus. Those patients, a lot of those patients will never develop lupus, but a small percentage may. And that may be there before the diagnosis of ITP is made, or it may happen weeks, months, or some considerable while later. So it's always important to be on the alert. There may be something else developing in the background, and clearly the tests that you're having done with the biopsy are important to exclude other things. So they're doing the right thing.
Okay, thanks very much. Right, the gentleman, but the name says Trudy, so I don't think that's your actual name with your hand up. You got a question, sir?
Hi, yeah, that's my wife. I'm David.
Nice to meet you, David.
Hi. It's the person which has ITP is our son. He's 2 years old. And he was diagnosed maybe, was it 3 months?
3 months ago.
3 months ago. He's had various treatments. Nothing has worked so far.
And his blood count's been
and
below 5.
And his platelet count has been below 5 for the whole time. Only today he had a blood test, had the test done today, and it said it was at 5, and that's after he started another treatment, which is N-plate. But we don't know if it's associated with that or not, or if it's just gone up. My question really is what kind of treatments are there for children? Is it the same as what's available for adults, or is it a limited number which is available? Because the only one which is left, well, there's 2 left which they've mentioned, which is after this is rituximab, and then it's doing stem cell treatment, so getting rid of his immune system.
Okay, Will, do you want to go with this one?
Yeah, I mean, virtually all of the therapies we use in adults can be used in children. I mean, stem cell transplant is really the last resort. You know, we wouldn't go down that route unless we've tried absolutely everything else. And it doesn't sound like you've got to that position yet. I mean, in terms of, I presume there are issues with bleeding. Is that
so far there hasn't been issues with bleeding. All that he has at the moment is a large number of bruising, any kind of bumps, and he gets large swellings. And what was the prick thing?
Petechia.
Petechias getting it as well. And that's all he has at the moment. So he seems he's okay. It's just that the fact that he's 2 years old, and you can't exactly keep control of him all the time, as in he bangs his head quite a lot because going underneath furniture, coming up, smacking himself, and that's the biggest risk that we really see with him is banging his head a little too hard, and could get bleeding in his brain, and that's could be the end of him with that. So
I mean, with just the petechiae and the bruising, no one would want to proceed to something like a stem cell transplant in in ITP, and particularly in pediatric ITP. It's something that would be a very long way down the road, and there are other treatments to try first. I mean, one of the important things about kids is they'll often either grow out of it or the platelet count drifts up. So it's a question of tiding them over. Of course, that's extremely difficult in a 3-year-old when they're running around a lot and bumping into things and don't quite understand all these things. And of course, giving them steroids makes it worse. Steroids will make them hyperactive, want to eat a lot, and they won't want to sleep, and all those sort of things.
They tried steroids as well. That was the one which we did before N-plate.
Yeah,
didn't make any difference at all with him as well on that either. And it was difficult to get him to take it because it was in tablet form.
Yeah, I can understand that. I mean, just for the others, N-plate is romiplastin, which is the treatment that Anthony was talking about earlier that stimulates your platelets. Now, that's almost as effective in children as it is in adults. And there is the Eltrombopag as well to come on to if that doesn't work, but it's worth giving that a reasonable try. There are almost certainly pediatric presentations on our YouTube thing, and our convention next May, we'll have a specific pediatric presentation to discuss treatment options and newer treatments. I know that's May, that's a long way off, but I would suggest, and I'm sure Anthony will know this better than I, but there will be presentations on our YouTube channel that will discuss that. But I would still want to be cautiously optimistic and supportive of you that romiplastin has a good chance of working. There are other treatments that well work. It's a question of tiding your 3-year-old over until the platelet count drifts up if it doesn't respond rapidly to the treatment, and the romiplastin or the N-plate needs to have a good chance to do that. So
we've had what were the different treatments? The last one which we had before Revelada was before the steroid test. That was only one treatment.
It was a high dosage, 4 days of high dosage cure. Yeah. And then he's had the one in
he had a transfusion. He had a couple of transfusions as well of platelets.
Yeah, that didn't work.
Didn't do anything. Didn't raise it above 5. He had the first 2.
Yeah, that's the one I can't remember. It was intravenous, but yeah.
He had the very first time he went into hospital as well over it because he was taken in. He had it was 2 different types of intravenous.
No, it's just the one.
Just one then.
Hemoglobin or something like this.
Immunoglobulin. He would have probably when the count's very low. They often give steroids and intravenous immunoglobulin to start with. Revelade, if they gave him that, that's the other name. That's the trade name for Eltrombopag, which is the other TPO. And as I said, N-plate is romiplastin. It's worth, those treatments have to have a good, some of these treatments don't work immediately. They need to be given for a short while to give them a chance to work. And if
we did the Revolada, we did that the full term.
Yeah, we did that up to the maximum dosage that I was allowed to have.
Yeah, and he was on that for 4 weeks on full dosage.
Yeah. Yes, I mean, Anthony's just put the thing is IVIG is possibly what he may have. That's another name for intravenous immunoglobulin, which is given as an infusion. I think the important thing is obviously not knowing where your treatment is and who's giving it, that you have a pediatrician who understands ITP supervising it, because there are only a small number who do that. It's quite a specialized treatment.
We live in Norway at the moment. We're in the north of Norway. He's been treated in hospital in Bodø, but he has a specialist which is in Oslo, which is in charge of his treatment.
Well, I know a very good specialist in Oslo, so it may be the same person. So he actually also.
We've been told that he's been in presentations going over into the UK and stuff like that as well.
It's the same one then, yeah.
Is it called Wally Ganima? He did come and talk at our convention last year. He's been a very keen supporter of our association. He's really expert in the condition, so I would certainly trust him with what he's doing, his decision making.
Okay. I mean, it sounds like the treatment is very much what you would get in the UK. Absolutely. I mean, and sometimes what may be the next step is combo treatment. So you don't necessarily have to give a single treatment, then another single treatment. Sometimes combination treatments can be effective when one drug on its own isn't effective. So I'm sure there are further things that can be done in this case.
Is there any specific type of combinations then that you're saying then?
There are lots of different combos. Yeah.
So you could combine increasing the platelet count production ones with the ones reducing the immune system.
Because we did the Hemoglobin was done together with transfusion of blood platelets, like blood plates. Yeah. That's the only combination we've done.
Okay. I see in the chat, Bonnie's put there that it took her 2 months to respond to TPOs, Nplate and Revelade. So you say your son's, your child's been on it for a month so far.
Yeah.
Well, no, it was more than a month.
It was on
8 weeks.
For about 8 weeks for Revelade.
Okay.
And that was up to his maximum dosage that he could be given, because it's supposed to be for a maximum of 4 weeks, isn't it? After
full dosage,
you reach your max dosage.
Okay.
Yeah.
And he got to that, didn't do anything. So then that's when they tried the steroids, one high dosage, to see, because they don't want to give him steroids as an actual treatment. They just wanted to see if it was going to affect him as a backup, just in case.
Yeah, I understand.
Didn't do anything. And that's when we're now on Nplate, and had his second dosage now.
Yeah.
Okay.
And again, because his weight, he's very small.
Tiny.
It's not going to be going up to a great deal, and so that'll be probably maxing out. I think it is in 14 weeks.
Yeah. Well, that certainly needs to be given. I mean, these treatments need to be given to their maximum dose, as you said, for at least a month afterwards, and that can take a while to do so. But as I said, the people looking after him out supervising the treatment, I've got great faith in, and and as Will said, you're clearly getting the sort of treatment we would be offering here. There's nothing strange at all about what they're doing. It's exactly the sort of course we would do here.
Okay. Thank you very much. Thank you. Daniel Murphy, sir, you got your hand up?
Hi, yeah. So I'm 2 weeks in. 2.5 weeks ago, hadn't heard of any of this. It's all a bit of a shock. Avid runner, climber, cyclist, kind of locked all them in a cupboard at the moment. I'm 2 weeks in on a high dose of the prednisolone steroids. And it's more about hearing about people talk about the fatigue. My issue is kind of concentration at the moment. I can't keep, you might have seen me on my phone and ticking around here. I can't focus on stuff. So, I am signed off work at the moment. I don't know whether that would be from the steroids or from like the stress and the shock and having to explain to everyone. And I just want to know how other people kind of dealt with that kind of agitation, I suppose.
Okay. Yeah. Well, let's go to the doctors first.
Could I mean, as a clinician, I'll speak. Yeah, steroids are they're great, but they're also evil, and they completely mess your mind up. Are you sleeping at all?
Yeah.
I mean, they cause insomnia, they cause mood swings, they cause agitation, they make you want to eat, they affect your sugars, they affect your bones. So I say it's a fantastic early drug. It's really good to get your platelets up, but it will make your mind foggy. It will make you struggle to concentrate. A lot of this will be steroids. Some of it will be the upheaval and the shock of the diagnosis, and I think but most of it will be the steroids.
Okay.
And
it was nice to see everyone nodding as you were agreeing with a lot of that.
Just so you're aware, we in the past, so historically, we were as clinicians, we were inappropriately kept people on steroids too long. People will be on steroids for months and months and months, and we have new guidance that says we really should not be giving people steroids for that long, and within 6 weeks we should really be getting them weaned down.
Okay.
And so I think the key thing is don't end up getting stuck on them too long. That they need to be weaned in a timely fashion. That is the modern way of thinking. And I say it's early days for you.
Yeah.
But a lot of this, you will, once the steroid dose comes down, you'll feel a lot better.
Go on.
I used to add being on steroids for 6 weeks were the worst 6 weeks of my life. And I would basically say, if you can get off them tomorrow, get off them. Because ITP isn't as bad as what the steroids make you feel. And that's, I would say, exactly what we were saying. I describe myself as a slug on diazepam. I just couldn't do anything. It was like my veins were full of concrete. I couldn't think straight. I couldn't work. I came off them. And then I had a lot of fatigue from ITP, but it was a different level of life fatigue. Yeah. And I would say to anyone, don't go near the things. If you can come off them, then get off them.
Well, what I would say as well, Daniel. Go on, Adrian. Go on.
I was going to say a patient survey some while back. 25% of patients, when asked, said they would never ever take steroids again because of those side effects. Yeah. It can be that unpleasant.
In the chat, Daniel, loads of people have put in that, some comments on your question as well. And, how it's really
reassuring because I've been in a few wards, but no one else has it in the ward, and obviously the internet is a scary place, but this place seems like you guys have been through it, so it's really but I could do with getting off these pills.
Whereabouts are you based, Daniel?
So I'm in South Yorkshire, and it has been really quick, really amazing. I've been in clinic every Friday, and it was only from a few bruises on my belly that I wasn't going to phone the GP because I'm too busy. So just because I made that phone call, it's kind of like changed everything. But for the best, they've caught me at the right time. But
we're always at the end of the phone as well, Daniel. So if you ever want to chat,
brilliant. Thank you, Mervyn.
Just pick up the phone. Okay.
Thanks.
Marilyn, you're next, I believe. You got a hand up? That's it.
Sorry.
Okay.
I would just say, big support to Daniel there, because been there, done there, got the T-shirt. Anyway, I'm new to the ITP Support Association. I was followed for 14, 15 years because my platelets were low. Suddenly, when I had a routine blood test in the spring of this year, I was found to have very low platelets. I read just briefly in the the newsletter that comes out that they call the platelet.
Yeah.
I only just had a quick glance at it, that there is some correlation, they suspect, between atorvastatin and ITP. And I was put on atorvastatin very successfully, actually. It made the small difference that was needed in my blood cholesterol level. And I was put on that sometime last year. And so that just suddenly pulled me up rather short. Could anybody make any comment about that? Well, should I be onto my GP yelling and screaming or what?
It's worth considering, and I think I wrote the answer to the question about are platelets affected by atorvastatin, and it's quite well recognised that in a small but significant proportion of patients who've been on atorvastatin, that it may knock the platelet count down. It doesn't necessarily. It can occur soon after you've started it. It can occur when you've been on it for weeks or a few months. So as Will said earlier, any drug, any side effect can be caused by almost any drug, and the only true way of knowing whether it's related to that is stopping that drug and seeing what the response is. But I certainly think that's worth pursuing.
Okay, and is it just atorvastatin? Would other statins be different?
It could do, but it's described much more with atorvastatin than with the others.
Right. Okay. Okay, thanks very much. I'll get in touch with my GP. Thank you.
Thank you very much, Marilyn. Sophie, you've got your hand up.
Hi. Yeah, I'm in a similar boat to Trudy and her husband. I've got a little boy who's 2 in January, and we are about 6 weeks in finding out he's got ITP. He started at 6, and fortunately he has gone up. And on Friday, he was at 34. So I think that's really good news from, what we're doing. He's had very small, like nosebleeds, but otherwise no other bleeding. But we have been in hospital 3 times where you know, unfortunately he's bumped his head or fallen over, and he gets the bruising and the petechiae as well. But the doctor said about not doing anything, so I was quite surprised to hear, you know, the other version where they're doing things. But I believe they said that they were still at 5. So just really a bit of advice, and if you think that's the right way to go and keep doing nothing for my little one.
Right, who wants to take that one up? Adrian, Will?
So did you say that they're not given treatment?
No, he's not had anything.
I mean, classically in childhood, ITP, maybe slightly older children, but is often triggered by a virus, and it often is transient, and it just gets better by itself. And it's all down to symptoms, and it sounds like that decision has been correct because the platelet count is coming up. Mm-hmm. And so I think that it sounds like good news.
Okay.
Yes, nice, and not exposing him to steroids, which would be the first step of the trial, has to be a good thing. I mean, as you've heard, but if you can get away with it, then it's best to observe. And clearly, when he bumps himself, they'll be clinically assessing him, and I'm sure would leap in with treatment if they're in any way worried. I'm sure they're doing the right thing. And again, just want to reassure you. And I think Will's comment is the correct one.
Okay, lovely. Thank you.
Thank you, Sophie. Right, we've got 3 minutes left, ladies and gentlemen. So one last question. Anyone want to put their hand up for one last question? God, I sound like a salesman here in an auction house. Sue, you got your... No?
Since we've talked about the drugs, do you want to let Will, do you want to take that question about the the drugs?
Is that the one that you mentioned earlier about MABs?
Yeah, that's right. Yeah, just so people get a better understanding, because there's been a bit of discussion about that tonight. I mean,
this gets back to this drug naming business, but some drugs have end in the 3 letters MAB. So rituximab is one of them, and generally that will relate to an antibody therapy. So we all make antibodies against infection, COVID, etc. And the immune system is very powerful. And obviously, autoimmunity is what happens in ITP, where you're making antibodies against your own platelets. But you can use the power of antibodies. You can manufacture antibodies or variants of antibodies which target very specific things. In the case of rituximab, it targets the cells that make antibodies, actually. But they tend to have the term MAB at the end. But there were lots and lots of them being developed for loads of different diseases, and they all have incredibly complex names. And they're very difficult to pronounce, but they all end in MAB. And I think we're going to see more and more of these antibody therapies. I mean, Adrian was instrumental in the use of IVIG in human immunoglobulins to treat ITP. But we've moved away to some extent. We're moving away from having to use blood donors to get antibodies to manufacturing these things with very specific targets. And there are some therapies for ITP coming through which are based on antibody technology. I don't know whether they're going to be called MABs though, because some of them are not even full antibodies. They're sort of part antibodies. I don't know if that answers the question, but yeah, unfortunately, we're going to get more and more drugs with more and more complicated names. But if you see MAB at the end, it's antibody. It's an antibody technology.
Okay. Thank you, Rhonda. Right, I'd just like to thank everyone for logging in tonight. Big thank you to our 2 clinical experts, Professor Adrian Newland and Dr. Will Lester. Thank you, gentlemen, and also the board members, and of course, Rhonda, our patient mentor, for taking part, but more especially all of you for actually joining in. Just remember, it was mentioned earlier, we have got a annual patient convention at the Royal College of Pathologists in May. Details are on our website, so if you'd like to book tickets, it is in person. First one for 3 years, in-person event, so we're looking forward to it. So please come along, and hopefully we will have another one of these sometime early in the new year. But thank you, everyone.
I'll just make one point, Mervyn. I'm amazed we've got through an hour without discussing COVID, which, considering a year ago, we'd go through an hour and every question would be COVID related. So I'm really, really pleased about
this.
This
is actually the first one. The first
which
one.
is a shame
So-
because Will's an expert on COVID and he got a prize from the RC Path with Sue Pavord, who's done many of these with us as well. So I was going to push every COVID question onto Will. maybe next time.
You did say that, didn't you? Yeah.
That's COVID's like last year's news.
Yeah.
Let's move on.
Ladies and gentlemen, thank you very much. Cheerio. Take care.
Thank you, everybody.
Bye.
Good night. Good night.